Obstetric and gynecology is regarding the polar body releasing time. It's an MCQ, polar body releasing time. The first polar body usually it's released at the time of ovulation, whereas the second polar body usually it is released at the time of fertilization. Okay, this is an important MCQ. Next MCQ, which is the first site of hematopoiesis in a fetus? The first site of hematopoiesis in the fetus is the yolk sac. Okay, then the other MCQs which you have to know regarding the in obstetrics gynecology is oogonia. Oogonia at birth, there will be around 2 million oogonia, whereas maximum of 7 million oogonia can be present when the person, that the mother is inside the womb of his mother, that the girl child, when the girl child is inside the womb of the mother, a 6-month embryo, I can say a 6-month embryo, a girl child embryo will have this 7 million oogonia, but by the time of birth it will become 2 million. Okay, then you have to know a few things regarding the umbilical cord. The umbilical cord, the length of the umbilical cord will be 50 centimeters and it will have 2 arteries and 1 vein. In this vein, left is left. So left umbilical vein persists, whereas right umbilical vein disappears. Then coming to the most common site of ectopic pregnancy. Which is the most common site of ectopic pregnancy? The most common site of ectopic pregnancy is exactly ampulla. It is the site of ectopic pregnancy. And also this ampulla is the site of fertilization. Usually it is a site of fertilization, and after that the fertilized zygote will travel to the uterus, and then in the uterus it will get embedded into the myometrium. It will become it will become a part of the endometrium, and thereby the process of yolk sac formation and everything takes place. And ampulla, being the widest part of the fallopian tube, favors this thing. Then coming to the hormones which are important. Oxytocin. What is oxytocin? Oxytocin is a love hormone, right? So it peaks at birth when the child is born, and because of this hormone only the milk ejection takes place. Okay, milk ejection. Okay, only coming out, only the milk ejection takes place. That is nothing but galactokinesis. Whereas this prolactin is a hormone where it is decreased in labor and also peaks at birth and causes the milk secretion. That is lactogenesis. Okay, so both the estrogen as well as the progesterone prepares the breast for milk secretion. Okay, then coming to few drugs. The drug that promote the lactation is metoclopramide. The drug which suppresses the lactation is nothing but gabercholine. And also the bromocriptine. So gabercholine and then the bromocriptine. So this is how the hormonal pattern will be. Then coming to the pH of the vagina. The vaginal pH. In case of a newborn girl child, the vaginal pH will be 5.7, pretty acidic. Then Before puberty, it will become less than 7. During their reproductive life, the pH of the vagina will be 4.5. And during menopause, the pH of the vagina will be more than 7. Okay, then coming to the cervix uterine cervix ratio, how it will be. You know, there is a uterus and below that is the cervix, and then comes the vagina. Uterus, cervix, this part is the cervix, and then the vagina. Uterocervix ratio. The uterocervix ratio before puberty is 1:2. At puberty will be 2:1. During reproduction will be 4:1. Okay. Then we saw the site of hematopoiesis, right? And the first site of hematopoiesis which we discussed was the yolk sac. Then what is the second site of hematopoiesis? That is the liver. Usually it takes over by 10th week. Then the third site of hematopoiesis will be the bone marrow at 20th week. Then coming to the fetal development and the weeks in which, I think we saw this earlier also, but still let me summarize. The 0th day we consider as the fertilization time or the fertilization day. 30 hours will be the true cell stage. 4th day will be the 16th cell stage, that is the morula. 6th day will be the blastocyst. 11th day will be the interstitial implantation. Then 12th day will be the uteroplacental circulation. It will start forming, and 650 ml per minute of blood will go to that fetus. Then 22nd day will be the feto-placental circulation that forms. It will be 125 ml per kg per minute will be the circulation. Feto-placental circulation will be formed. 8th week will be the formation of primordial follicles, as well as internal genital organs formed. And also 12th week will be the time when pancreas starts secreting insulin, external genitalia forms, kidney starts to secrete urine, and then amniotic fluid will be deducted. Okay, then by 20th week, the fetal urine will get filled with amniotic fluid, and more amniotic fluid will be deducted. These are the fetal development period that's very significant for you. Then coming to the this number of weeks and the level of the uterus. If they, for example, if it's 24 weeks, the level of the uterus, the topmost part of the uterus, it will be at the level of the upper umbilicus. 22nd week, it will be the mid umbilicus. 20th week will be the lower umbilicus. Okay. Then 12th week means it will be in the pubic symphysis level. If the dome of the uterus is up to the xiphoid of the sternum, what will be the weeks expected? It will be 36 weeks. Okay. First, it will come to the xiphoid level. and then to the upper umbilical level, then umbilicus level, then lower umbilical level, and then the synthesis pubic level. And finally will be the process. Okay, these are things that you have to know. Then you have to know about the pelvic diameters, which is the greatest pelvic diameter. Greatest pelvic diameter will be anteroposterior diameter, that will be 12 centimeters, or the transverse diameter, that will also be 12 centimeters. Then least pelvic diameter will be the posterior sagittal diameter, that will be of 5 centimeters. Okay. Then in an ultrasound, you have to know the age of the fetus. In order to know the age of the fetus, you have few parameters. If it's the first trimester, then the crown rump length measurement will give us an idea about the age of the fetus. If it's the second trimester, then biparietal diameter. Biparietal diameter will help me with the finding the what do you call it? Biparietal diameter will help me finding the age of the fetus. If it's the third trimester, then the femur length. Measuring the femur length will help in the diagnosis of the age of the fetus. And we know, of course, we know HCG will be increased in case of pregnancy. HCG, you should know about the doubling time of HCG. The doubling time of human chorionic gonadotropin will be 48 hours, and it peaks at 10 weeks. Okay, then it peaks at 10 weeks. Then you have few important things that you have to know. That is, who is a nulli gravida? Nulli gravida is a female who has never become pregnant. Primi gravida. Primi gravida is the one with first pregnancy. Then multigravida is the one with 2 or more pregnancy. Then nulliparity is who has never given birth, who might have conceived but never given birth. Primiparity, given birth to 1. Multiparity will be given birth to 2 or more, whom you called grand multiparity. Grand multiparity. Grand multiparity is 5 or more birth. Okay. Then great grand multiparity is we have 10 or more birth. This is what you call it as grand multiparity and great grand multiparity. Then coming to the signs of pregnancy that you have to remember. In the first trimester, you will have Chadwick sign positive. Then Heger's sign will be positive. Heger's sign, the upper part of the uterus will feel firm and the lower part will feel empty. That is Checker's sign. Chadwick is that violet, bluish discoloration of the anterior vagina. This Chadwick sign will get positive by 8th week. That Heger's sign will get positive by 6 to 10 weeks. Then the Oslander sign. Oslander sign is the inferior sensation felt to the lateral fornix. This will happen by the 8th weeks. Then the Palmer sign. That means the rhythmic uterine contracture during bimanual examination. This Palmer sign will be seen in first trimester, and then this Goodell sign. The Goodell sign is the softening of the cervix. Softening of the cervix. This will all be seen in the first trimester. How about in the second trimester? In second trimester, you have quickening. Quickening means nothing but the movement of the child is felt. And then the ballotment will be seen. Then the third trimester, you have the lightning sign. Lightning sign means the head will go and flex below so that the heaviness that was felt by the mother will become lightened now. Because the child has moved inside the pelvis, the heavy abdomen will be reduced. So this will be the lightning sign or the welcome sign that will be seen in the third trimester. So these are the signs of pregnancy. Then what are the best time for the tests? Say for example, the best time to go for a transvaginal ultrasonography. Sonography is 8 to 10 weeks. Then the best time for the ultrasound to rule out the congenital anomalies is by 18 to 20 weeks. Then the best time for placental localization. The best time for placental localization is the third trimester. Then what you identify in this early pregnancy, you identify the gestational sac in case of early pregnancy. Then coming to the stages of labor, you have the first stage of labor, second stage of labor, third stage of labor, and the fourth stage of labor. In this, the first stage, what will happen? It's the time of onset of true labor until the cervix is 10 centimeter dilated. Okay. Now, second stage of labor is from 10 centimeter cervix dilatation to the childbirth. Third stage is the delivery of the placenta. And the fourth stage of labor is 1 hour after delivery of placenta. So these are the stages of labor. In this, the first stage of labor has different phases like early labor phase. It's the time of onset of labor up to 3 centimeter cervical dilation. Then active labor phase. That is continues from 3 centimeters up to 7 centimeters. Then the transition phase will be, it continues from 7 centimeters until the cervix is 10 centimeters. So this will be the early phase, active labor phase, and the transition phase. Okay. Then regarding the intrauterine pressure in first stage of labor, you have the intrauterine pressure will be 40 to 50 mmHg. Whereas in the second stage of labor, the intrauterine pressure will be 100 to 120 mmHg. In third stage of labor also the same pressure will be maintained, 100 to 120 mmHg pressure will be maintained. Okay. Then the different types of presenting parts, of course, face, shoulder, breech, cephalic, mentum can come, acromion, the shoulders can come, sacrum can come, vertex can come. So these are the, any part of the body can come. So it will be, those are the presenting parts. Then coming to the pre-labor scoring system that you have to know, whether the labor is going to progress or not. Is it a favorable sign or not? This pre-labor scoring system It's a modified Bishop scoring. Modified Bishop scoring system. The parameters include the position, consistency, cervical length, dilation, fetal station. Okay, if I have to score, I have score from 0, 1, 2, and 3. Position, if it's posterior, it's 0, middle, it's 1, anterior, it's 2. The maximum for position is 2. Consistency of the cervix, firm, medium, and soft. Cervical length more than 4 centimeters, 3 to 4 centimeters, 1 to 2 centimeters, and less than 1 centimeters. Less than 1 centimeter, score is 3. So that means that highly progressive for labor, favorable for labor. Dilatation, it's closed 0, 1 to 2 centimeters, 1. If it's minus 1, sorry, 3 to 4 centimeter, it's 2, and 5 plus centimeter will be 3. Fetal station, minus 3, minus 2, minus 1 and 0, and plus 1 and plus 2 will come under this. This is the category. So if you put on all the values and calculate it, the total score will be 13. Out of this 13, 16 to 13, if you get, is considered favorable for a normal labor. It's considered favorable for a normal labor. Whereas if you get less than 6, then it is unfavorable for a normal labor, and hence you have to move on with the proceed with the what is this? This LSS, lateral segment cesarean section. Okay, so this is the, sorry, not lateral segment, lower segment cesarean section. That is LSS. You keep saying LSS again and again. Sometimes you forget the sentence. Lower segment LSS. Then coming to the common, the obstetric pathologies, the most common type of twins will be the diamniotic monochorionic. Okay, diamniotic monochorionic. Most common type of a conjoined twin will be thoracophagous. Thorax will be attached to each other. Then the twin baby, most common presentation of the twin babies will also be the vertex. Then regarding delivering the twin babies, management of a twin normal labor, if the first baby is vertex, go for a normal delivery, normal vaginal delivery. If the first baby is transverse or a breech, then you go for a LSCS directly. If the first baby is vertex and you have delivered the baby, and the second baby is transverse, what to do? After delivering the first baby, you do an external cephalic version and then an internal podalic version to make the baby become vertex again, so that you can deliver the baby. External cephalic version followed by an internal podalic version. Okay, externally you rotate the baby, internally also you rotate the baby so that the head comes out and we can deliver the second baby. Then comes the deformities, that is the placenta previa. What is a placenta previa? Usually the placenta will be in the anterior border, whereas when the uterus is there and if the placenta is in the lower part of the uterus, if the placenta is attached to the lower part of the uterus, or if it is extending to up to the opening of the cervix, then you call this as a placenta previa. So usually in placenta previa, the main thing is painless and costless bleed. There be no reason, but it will bleed. Painless and costless bleed. Okay. Then vaginal examination is contraindicated. Vaginal examination is contraindicated in placenta previa. Then you have different types of placenta previa. Say, for example, if this is at this level of which I've drawn like this, the red color level, you call it as a low lying placenta. Okay. Then if it when this placenta comes to this margin also, cervical margin also, then you cover it as marginal type of placenta previa. When this placenta almost comes to partial obstruction of cervix, you call it as partial placenta previa. Then complete obstruction of this cervix, you call it as the complete placenta previa. Okay, this is what is the placenta previa, and the reason for concern is that it will bleed, and there are high chances of hypotension to happen because of this bleeding. And in these patients, usually, if it's a minor degree, you try a normal labor. If the degree is like, the amount of placenta, if in case of a marginal, partial, and a complete placenta, it's always good to go for an LSCS. And you do not give oxytocin for induction for all these things because it will end up in a massive bleeding. Then coming to an entity called as the abruptio placenta. What happens in an abruptio placenta? You will have a uterus, placenta will be there, but problem is the placenta would have abruptly disconnected from the uterus and it will be bleeding inside. Okay, it's a premature separation of the placenta from the uterus. Okay, and it will bleed inside. Usually this bleeding is a painful bleed. It's a painful bleed. Usually these patients will give a history of fall. Okay, and the uterus will be tender. Tender uterus will be seen. In case of if the bleeding is just arrested here, it's inside this area, you call it concealed bleeding. And then if you see this bleeding to be here and it also dripping out, then you call it as revealed bleeding. The bleeding is revealed outside. So the revealed abruptio placenta. Usually when you see an abruptio placenta, the treatment is just the termination of pregnancy. Either you do an oxytocin induction, or you go for when this normal labor fails, then you go for an LSCS. And you terminate the pregnancy at the earliest possible to save the mother. Fetus, it depends upon the age when the abruptio placenta is happening. Next, coming to the pregnancy hypertension, pregnancy-induced hypertension. Usually this pregnancy-induced hypertension, it is diagnosed like when you have an hypertension episode, BP more than 140/90, when this hypertensive episode is present more than 20 weeks of pregnancy. After 20 weeks of pregnancy, after 20 weeks, you call it as gestational hypertension. Along with this gestational hypertension, if you have proteinuria, along 300 milligrams of albumin, microalbuminuria, if it is there per day, then if this proteinuria is present, it becomes preeclampsia. Then if the hypertension was present even before 20 weeks of pregnancy itself, then and this hypertension will persist after delivery also. It's nothing but a chronic hypertension. Okay. How are we going to manage this hypertension? This pregnancy-induced hypertension, we are going to manage it with labetalol, beta blocker. Labetalol is the drug of choice for management of this pregnancy-induced hypertension. Then, if the patient goes for even if the patient goes for a preeclampsia, I'll treat with labetalol. But when the patient starts throwing seizures along with preeclampsia, if the patient starts to throw seizures, then it becomes an eclampsia. So this eclampsia treatment will be control of BP by labetalol infusion and then termination of pregnancy by most probably. It is not like you cannot try a normal labor in this patient. It depends upon there is a fetal indication should be there for an LSCS. If not, then you can give, if the person is awake and able to push the baby out, you can give. And the main drug of choice for eclampsia is the magnesium sulfate. Magnesium sulfate is the main drug of choice for eclampsia. And use the Pitchard's regimen for treatment. In India, most commonly used is the Pitchard's regimen, where they give around 4 grams of this 20% of magnesium sulfate IV, then followed by each buttock, 5 grams in each buttocks every 4th hourly, and they'll keep continuing. And during magnesium sulfate therapy, they monitor the urine output, then deep tendon reflex, then respiratory depression. These are the 3 things that has to be monitored while giving magnesium sulfate. Then coming to the color of the amniotic fluid and the possible diagnosis. The color of the amniotic fluid is green in color. It's a Sundar, are you there?
Yes, ma'am.
Okay, good. So if it's green in color, it's meconium. Then if it's dark brown in color, intrauterine death. And also dark brown color could be because of the placental abruption. Then the saffron color is seen in case of post-maturity. Then yellow color is seen in case of RH incompatibility. RH incompatibility. Okay, so this is the amniotic fluid. Then comes the clues of septic abortion. In India, you have a lot of septic abortion. The patient will come with an abdomen pain, fever, and a foul-smelling vaginal discharge. If you ask them, they will say that the local lady who gives this Ayurvedic treatment, she uses some stick to enter inside the vagina, and she will just go inside your cervix, and inside the uterus, she'll make a rotation of that stick, and that will cause a septic abortion. Okay. Not all the time there will be this. Not all people will go to a gynecologist for an abortion, right? So illegal abortions, they go to this way and they end up having a septic abortion. In septic abortion, it will be life-threatening. There are chances that we can lose this patient in this way of abortion. So septic abortion is really alarming, and in India it's very, very common. I myself have lost around 2 to 3 patients because of this septic abortion. They come to us and they don't reveal that they have got a septic abortion also. And finally you dig it and then they will reveal it to you. And abortion is always a thing which we have to know. And the drugs used for abortion, initially they give mifepristone. And the mifepristone will it's an anti-progesterone agent. It will stop the growth of the fetus, and then followed 48 hours later by the misoprostol. This misoprostol will cause uterus soft tissue contraction, so that all the contents of the products of consumption just comes out of the uterus. Then coming to the types of abortion. You have threatened abortion, inevitable abortion, then incomplete abortion, and a complete abortion, then missed abortion. What is a threatened abortion? The threatened abortion, it happens when the cervix is closed. Cervical os will be closed here. And the ultrasound will show a live fetus. And the management is you have to give progesterones to continue the pregnancy since the fetus is live. Okay. Then inevitable abortion, here the cervix will be open. Ultrasound will have a dead fetus. The only thing is to induce labor, or you do a dilatation and curettage. You terminate the pregnancy. Incomplete labor with an cervical os open, and the retained products of consumption might be seen in ultrasound. Like half product would have gone out and retained products will be there. 10 products of consumption will be there, and this has to be let out by DMC, dilatation and curettage. Then complete abortion, the cervical os will be closed, and the ultrasound you see then empty uterine cavity. That means that the abortion is complete and you don't have to do anything about it. Missed abortion is very important. No, they don't know that they got aborted. Most of the time it will happen like the very young mothers, less than 20-year-old mothers, they have this problem. They will not be able to realize that the baby is moving or not. So these will have a brownish discharge coming out of them, and here the cervical os will be closed, and the fetus will be a dead fetus in case of missed abortion. And when ultimately you have to go for the termination of pregnancy, and here the problem is that the dead fetus is a high risk factor for DIC, disseminated intravascular coagulation. They carry a very high risk for a disseminated intravascular coagulation, and henceforth we always avoid. We have to remove the dead fetus at the earliest possible from the mother's uterus. Then going to the gynecology topic, the causes of primary amenorrhea. Primary amenorrhea means the patient has never attained menarche in life. This is primary amenorrhea. In this, you have the syndromes that you have to know. Turner syndrome. Turner syndrome is XO, right? And it is in this Turner syndrome, you have delayed puberty. Because X chromosome is not there, how are we going to treat it? The treatment is via estrogen and growth hormone. Then testicular feminizing syndrome. Testicular feminization syndrome. Here, the chromosome will be 46XY. The breast will be normal for this patient, but the problem is there will be absence of uterus, fallopian tube, and the upper vagina. Okay, testicular feminizing treatment is hormonal replacement therapy. Then Mullerian agenesis. Mullerian agenesis. In this, you will have 46XX. Okay, if you see this 46XX, breasts will be normal. Axillary hair will be present. Pubic hair is present, and it will be, everything will sound normal. Pubic hair is present, and ovary will also be present. But the thing is that you will not have a vagina, so you have to do a vaginoplasty. So the treatment is via vaginoplasty. Next, coming to the imperforate hymen. This imperforate hymen is the otherwise called as the hematocolpus. We call it as hematocolpus or imperforate hymen. What happens here? Here the girl will be getting cyclical bleeding every month, but it won't come out. Cyclical bleed will be there, but it won't come out. It won't come out. So if you see, the patient will have abdomen pain and infections. So what you do an examination of the vagina. That time you see something called as the bulging blue colored membrane in the vagina. That is the hymen. It is not perforate. Usually the hymen has to be like, there will be small perforation inside the hymen, so that this whatever the endometrial shedding that happens comes out through that small holes. If that is not there, then everything will get connected and become infected. So the treatment, the primary treatment will be an incision and drainage. You put an incision, drain all the collections, and secondary treatment could be conization. Okay, this is how you treat the primary amenorrhea. Then coming to the secondary amenorrhea. Of course, the most common cause of secondary amenorrhea is pregnancy. Okay, in a normal person, the most common cause of secondary amenorrhea is pregnancy. But it also happens in other syndromes like Asherman syndrome. What is an Asherman syndrome? Asherman syndrome, the features is oligomenorrhea, secondary amenorrhea, infertility. Then investigations, you have this ultrasound and hysteroscopy. And how do we treat it? The problem here is in Asherman syndrome, what is the problem here? The problem here is the adhesions that happens inside the uterus. So that is why you do an hysteroscopy to find out the problem. So the treatment is adhesionolysis. Then coming to the PCOD, polycystic ovarian disease, or the Steen-Levenshtein disease. Steen-Levenshtein syndrome. In Steen-Levenshtein syndrome, you will have obesity, oligomenorrhea, infertility, then hirsutism will be there. And here in ultrasound, you will have the necklace or a string of pearl appearance, or the necklace pattern of ovaries. Sorry, ovarian follicles, or the cysts, not the follicles, cysts. So necklace pattern of the cysts will be seen in the ovary. And here you will have an increased LH to FSH ratio. Okay. The treatment here is, you treat this patient usually with metformin. But if you want this patient to go for a infertility treatment, then the ovulation trigger drug will be clomiphene citrate. If you take clomiphene citrate, the chances of ovulation is there.